Great. So we're going to go ahead and get started. I'm going to start by introducing myself to many of you who may not know who I am. Some may already know. I am Darrell Holly. I'm the National Lab Administrator here at MNADV, and I've been with the network since 2019. All right, great. So we're going to go ahead and get started. I'm going to start by introducing myself to many of you who may not know who I am. So housekeeping real quick. At the bottom of your screen, there's a Q&A section. We ask that anyone have any questions at any time during the presentation, please submit those questions in the Q&A section, and we will address it at the Q&A segment of this at this webinar. Also, if you have any questions about LAP as far as the implementation, I know a lot of people may have some questions or concerns about the LAP 2.0 and implementing. Because this topic in this webinar is addressing the strangulation and the changes to the tool, particularly the strangulation question, we would ask that you email those questions to us at lapinfo@mnadv.org, and we'll address your questions as soon as possible. If you would like meetings or anything like that, still use the same email address, and we'll get that information to you as soon as possible. There have been questions about the strangulation question we have on our lethality screen and the updates that we made. And if I could talk about this just briefly, as most people know, back in October of, I believe it was 2020, Maryland took a step in the right direction by making strangulation a felony, right? And we noticed that it became something that the majority of the states in the country decided was important enough to make a felony as well. So non-lethality strangulation became a felony in 48 of the 50 states, right? So here at the network, since we had strangulation as a question, we wanted to look at it and see if that question where we had it on a tool and the amount of weight it had with identifying intimate partner homicide was accurate. So in that, we started to begin to kind of look at strangulation as itself, right? So we know that strangulation, the effects of it can be delayed. We know that non-fatal strangulation victims are at a higher risk of homicide. And we know that sometimes strangulation itself physically may not be identified, right? We know that there are some causes of that, or there's some effects of strangulation that can affect the nervous system, that can affect the spinal cord, you know, headaches, raspy voice, and things like that, right? Maryland classified strangulation as a felony in October. We know there's some residual effects of strangulation in that it's something that is spotlight, right? So what we did at MNADV, we started to look at strangulation on the screen, and you know, how is it relevant to the screen? Is it something that is in the correct place? So we would have these discussions in our multidisciplinary advisory council team. Now, our advisory council were a group of professionals from all over the country, not just exclusive to Maryland. We had attorneys, we had retired law enforcement, we had nurses, we had our researchers, we had, you know, Dr. Campbell, who was an intricate part of our team, as well as Dave Sargent and Dave Thomas, who worked at the core and the foundation when LAP was founded and implemented. We really wanted to have a very diverse group of professionals that are affected by or work with domestic violence. We had some executive directors of programs, again, people who work out of the Attorney General's office. So we had some people that are looking at laws and again, like I say, lawyers who are looking at the legal aspects of it, because we wanted to make sure that whatever we put together was well-rounded and well-represented to address needs of all of the communities we have, right? So with that advisory council, like I said, we started to talk about the strangulation through the LAP tool, okay? So we began a process of really looking at the strangulation question. Data from strangulation started to become more prevalent, or studies, I should say, of the LAP has become more prevalent. You see a lot of articles dealing with strangulation. Dr. Campbell is one who's doing some great work with strangulation as well. You have the Strangulation Institute and various other programs that really spearhead this move to look at non-fatal strangulation, as well as fatal strangulation, right? So we began to reevaluate of our LAP screen. And we had multiple ideas on how can we make strangulation have the emphasis that it needs, right? So we looked at moving strangulation above the line without changing anything else, right? Having 4 questions above the line. So we presented this information to Jill Messing, who was one of the leading researchers from the Oklahoma study that evaluated the LAP tool. And we gave her some ideas of like, how can we really show that this is a high importance topic, right? And Jill later, she'll tell you how she came to her conclusion and her portion. So I don't want to speak too much into that because she has a very awesome presentation about that. Now, we also looked at how the strangulation in law enforcement, how are law enforcement affected by strangulation? How do they view strangulation? How can they provide input about strangulation, right? So, with that, we leaned on our law enforcement officers to give us information, because they're at times the first responders on the scene, and they see and they hear the testimonies of survivors about strangulation. So that input was very crucial as well. Okay, so now what we're going to do is I want you guys to hear from Dave Thomas, and he's going to talk about the strangulation from a law enforcement perspective. Okay, so Dave Thomas is an IACP program manager, primarily focused. Let me remove this. There you go. Primarily focused on projects pertaining to National Law Enforcement Leadership Initiative on Violence Against Women, funded by OVW, the Law Enforcement-Based Direct Victim Service Project, founded by OVC, the Promising Practices in Law Enforcement Victim Support Project, funded by OVC, the National Sexual Assault Kit Initiative Project, funded by BJA, the Improving Community Preparedness to Assist Victims of Mass Violence or Domestic Terrorism Training and Technical Assistance Project, funded by OVC, and the Military Training and Technical Assistance Project, funded by OVW. So without further ado, I'm going to introduce my good friend, Dave Thomas.
Good afternoon, and thank you so much for that introduction and for having me with you all today. I think it's paramount that we really that we're recognizing how significant that nexus is between strangulation and lethality. I remember back in 2004 when the people from the Strangulation Institute came out to Maryland through the Maryland Network Against Domestic Violence and Johns Hopkins, and we did training on this. And since then, I've been fortunate enough to work with them on this topic and continue to learn more about strangulation in particular and lethality and how they meet up. Since 2013, they really started looking at this nexus and what percentage of individuals who end up dying in domestic violence relationships had strangulation, what victims had strangulation as a factor. And even looking at how these individuals end up, these perpetrators end up not only being dangerous to their significant other, up to the point of lethality, but also third parties, their families, interveners, law enforcement. You know, men who assault and strangle women are really some of the most dangerous men on the planet. And many professionals, including law enforcement officers, continue to miss this truth. You know, almost 30% of last year's line of duty deaths by firearm, 22 out of 64 came at the hands of one of these types of predators. And 22 in 1 year, that's 6 more than the previous high of 2016. Now, already this year, 1 out of the 2 officers murdered by firearms lost their hands at the lives of this category of perpetrator. The research is clear. When a man puts his hands around a woman's neck, he basically has just raised his hand and said, I'm a killer. He is more likely to kill police, to kill children, and to later kill his partner. Thus, each and every time we get a report of or suspect intimate partner abuse, we have to really make every attempt to cross every T, dot every I, and routinely utilize all the tools at our disposal in our efforts to make the law keep its promise of establishing safety for all and holding perpetrators accountable. You know, a common thread and theme driven home from day one in the police academy and reiterated throughout an officer's career is making sure that everyone goes home safe. Maintaining this safety really entails recognizing danger signs, being made aware of potential hazards, and taking nothing for granted. You know, in Casey Gwynn's article, who's the president and co-founder of the Family Justice Alliance, in his article titled "Men Who Strangle Women Also Kill Cops," he informs us that the large majority of men who kill police officers in the U.S. are domestic violence offenders, and most of them have strangled at least one woman in an intimate partner relationship before they ended up killing a police officer. A history of strangulation assault with women is not only the purview of cop killers. The research informs us that the majority of mass shootings, domestic terrorists, and domestic violence killers in the country have 2 things in common: a childhood trauma history and prior history of domestic violence, and often strangulation, assault against women, or they kill women, police officers, and others. You know, an analysis by Bloomberg News found that between 2014 and 2019, almost 60% of shooting incidents with 4 or more casualties involved an aggressor with a history of domestic violence or in the act of domestic violence. And that's 2,358 incidents. One of these offenders, Devin P. Kelly, murdered 26 people in a Texas church in 2017. You might remember that incident. His documented past included a history of choking, physical and sexual attacks, and threatening to kill his ex-wives. Agency executives must commit and continue to commit to implementation of the lethality assessments as a component of the investigatory process. In crimes of interpersonal violence, this vital step may very well be the difference between life and death. All in all, it's essential for us to put the proper focus on this issue, to maintain efforts to keep victims and the communities we live in safe, and to make the law keep its promise. This is one of the ways we can continue to do this, one of the tools that we can utilize. And this question is imperative that we ask it, we recognize it for the significance that it plays, and that we move forward together and continue to learn, continue to make efforts to always improve on those things that we're doing. Thank you.
Thank you, Dave, so much for that. That's very helpful and useful information, and it sheds a lot of light on what we know about strangulation, or what we think we know. and from law enforcement's perspective, that's definitely something we need to know. Just understanding that someone who strangles is more dangerous or more likely to kill an officer, that's powerful. So thank you for that. All right, so you just heard from law enforcement. Now I want to bring Dr. Jackie Campbell up next. Dr. Campbell is going to talk about strangulation as it results to the lap as well. So again, Dr. Campbell is a professor at the Johns Hopkins University School of Nursing. She has published more than 300 articles in 7 books and is the principal investigator of more than 15 major NIH, CDC, and NIJ grants in her decades of advocacy, policy work, collaborating with domestic violence services, advocates, healthcare professionals, and marginalized communities. She is particularly known for her research on domestic violence, homicide, and the development and validation of the danger assessment. That helps IPV survivors more accurately assess their risk of being killed or almost killed by their abusive partner, which is used widely in the US and globally. So without further ado, Dr. Jacqueline Campbell.
Hello, everyone, and I'm delighted to be here, especially delighted to be presenting with my friends and colleagues at MNADV and Dave Thomas and Jill Messing. Next slide, please. And just briefly, we all know this, but intimate partner violence, sexual violence, and stalking against partners are widespread, impacting millions of Americans every year. Next slide. And when we think about the gender differences, 27% of women have experienced intimate partner violence to the extent that they have serious injuries or PTSD. And other long-term effects. And 12% of men are also abused by intimate partners. And one of the things I oftentimes think about is what we don't know is how many men who are in an intimate relationship with another man, how often strangulation is part of the abuse that one partner puts on the other. And this is something that we really need to learn more about. But what we do know about, next slide, is that women experience strangulation from an intimate partner far more than do men. And you can see that, that stark difference here. Next slide. Oh, I forgot I had some other things that were supposed to fly in there. And in terms of prevalence, if you look globally, that we find a lifetime prevalence for all women of 5%. Now, these are not just abused women. These are all women in general. And the highest rates of strangulation are in the United States. And I'm not quite sure why that is, but we do have data that strangulation, intimate partner strangulation does happen in other countries, but here in the United States more so than other countries. And in abused women, in the research that we did for the intimate partner femicide study in early 2000, 10% of abused women who were not seriously abused, they had never experienced near lethal violence from a partner, 10% of them had been strangled at least once, while 50% of the women who were murdered or almost murdered had experienced strangulation at the hands of that partner who killed them at least once. And The risk for lethality, one of the things we know is that 11% of all women who are murdered in this country are strangled to death. And that strangulation was probably, that caused her death, was probably not the first time she had been strangled by him. And what we have found in our work, that non-fatal intimate partner strangulation of women increases the risk by 6 times the odds of attempted homicide against her, and over 7 times the odds of a completed homicide. And one of the things that Jill's wonderful work showed, that if she has been strangled more than once or to the point of losing consciousness, that increases the risk of a homicide even more. And one of the things we know is that strangulation can be fatal, and even though there's no external injuries that can be seen. Next slide. So the infographic on the right is available through the National Strangulation Institute. It gives the signs and symptoms of strangulation. Every emergency department in this country should have this infographic and a protocol for detecting, for finding out about strangulation from a patient, and for having the right scans ordered, etc. So what I always tell people is, if your emergency department does not have a strangulation protocol in place, then be sure to send whatever emergency room physician is in charge of, especially of resources, send them to the National Strangulation Institute training. Scrape up the pennies to get that person there. They will come back and put a good strangulation protocol in place. And that's it. It can save lives. So that's incredibly important. We see not only those acute injuries, which are can result in loss of consciousness, but we also can see long-term or delayed presentation injuries, including a stroke. And so a woman who has been strangled can actually have a stroke if her carotid artery has been injured in the strangulation. She can have a stroke up to 5 days later. So it's incredibly important that we have those protocols in place in our emergency departments. It's also, many women have described how incredibly frightening it is to endure a strangulation, even if it's not fatal. And so we see, most of the time, we see symptoms of PTSD long after the strangulation. Multiple strangulations are associated with increased reports of physical and psychological symptoms. 50 to 90% of those reporting strangulation, however, have no externally visible injuries. But it's incredibly important that they get seen in an emergency department so that those internal exams and those appropriate scans can be done. And that way, the evidence of strangulation can be recorded, and the enhanced penalties from the law enforcement criminal justice side can be imposed on people who strangle other people, usually men who strangle women. Next slide. And so this is another infographic that's put out by the National Strangulation Institute. It just gives us some of the data that's available to back up what's being said, and emphasizing again that there's, even in fatal cases, there's oftentimes no external signs. One of the things that's also incredibly important, that your local emergency department have enhanced light that they can use that can actually pick up signs of strangulation, especially on dark skin, where it's oftentimes not seen. One of the things people always think that the petechiae, those little broken blood vessels, if someone's been strangled, that they show up in the whites of the eyes. Well, not necessarily. Oftentimes there's petechiae along the hairline. It depends on where the strangulation occurs, in terms of, is it hands around the neck, or is it a chokehold, for instance, which is unfortunately being taught in every mixed martial arts class in the United States. I think it should be against the law to teach it, but that's something else that we can work on along with other legal remedies. Next slide. And the danger assessment, there's the danger assessment website, was originally only 15 items, and a brilliant master's student that I was advising, Elaine Stewart, said, why don't we ask the women in support group if there's anything else that's not on that 15 item list that really scares them, that really makes them think they could die. And what they said is, when he chokes me. And that's one of the enduring things that we need to remember, is that oftentimes that women, if you say to an abused woman, does your husband or partner ever strangle you? Oftentimes you would say, well, no, I'd be dead, right? But if you use the word choke, and the danger assessment item on this does have the word choke / strangle, that way they can relate to it no matter what the mechanism was. Hands around the neck may or may not be the choking. A belt around the neck is also something that's been used, however horrific that seems, as well as chokeholds and forearm against the neck, against the wall. So there's many different ways that a woman can be strangled, that oftentimes the word strangle doesn't bring up to her. The item on the danger assessment also has cut off your breathing, so that can cover the tactic of a pillow over the head, which is sometimes used. And so the other thing in the danger assessment where strangulation is on the calendar, which is a very important part of the danger assessment and interactive process. And if she has been strangled, the instructions are for her to put a small C with a circle around it. And then whoever's doing the danger assessment with her can see at a glance if there's been more than one or more than one strangulation in the past year. Next slide. And this is what I just said. I forgot, I actually put a slide on it, but the forearm against the throat against the wall was what those women talked about. And that quote from the woman, it's like when he was choking, I could feel myself gasping for air. And it was like with each breath that was coming, it was just enough. And I'm slowly losing it. And those thoughts, he's just going to kill me. He's not going to let me go. And it was just how he had his hands around the neck, and I could see his eyes. The rage was just, and he was saying, I'm going to kill you, be able to kill you, like I was afraid he was going to do it. And that's from Michelle Patch's dissertation research on strangulation. That's so very powerful, but that gives you a sense of how horribly frightening this would be to anyone. And it also illustrates when she says, I'm slowly losing it. We oftentimes think, well, you lose consciousness, you're out. And if you're with it, if you're in consciousness, that you're in, all the way in. And it's actually a process of losing consciousness. Oftentimes starts with feeling dizzy, seeing spots before your eyes. And that is the process of slowly your brain being deprived of oxygen. That it isn't an all once kind of thing. So that's why we use the words, did it make you pass out or black out or make you dizzy on the danger assessment? Next slide. And this is just in a sample of women who came to one of Johns Hopkins outpatient clinics for other things. And we asked them whether they were being abused by a partner. And if they said yes, we asked them about losing consciousness from head injuries and or from strangulation. And 27% of those women who had never been to law enforcement for domestic violence, had never been to a shelter or shelter services, still 27% of them had been choked at least once. Next slide. And when we have updated the danger assessment, it used to, the choking, when you put it in along with other risk factors, but if it happens more than once or to unconsciousness, that jumps up the adjusted odds ratio. So we've added that second question to the danger assessment. Next slide. This is what we put on the calendar. If you look at number 4, which is the most severe domestic violence on the calendar, that the copyright sign, the C, is in the date to indicate choking, strangulation, cut off your breathing. Next slide. And Gail Strack and Casey Gwynn from the National Strangulation Training Institute helped me with the wording of this to get it right. This is from the Oklahoma study that Dorel mentioned in terms of it evaluating the LAP. And basically, when women at high risk on the LAP spoke with a domestic violence advocate on the phone at the scene, those women had significantly less severity and or frequency of violence afterwards. And they also increased their safety behaviors, actually going to a shelter or domestic violence service organization or a family justice center to get services after they had that event. They had called the police, and what we find, if they're not actually put in touch with domestic violence advocates at the scene, if they are given a phone number, they oftentimes do not follow up with seeking services from advocates. Next slide. And what we did find in that study was we also looked at the multiple strangulation versus one strangulation. And one of the things was that with multiple strangulation, there was a higher risk of homicide and near lethal injury, and also miscarriage, which is incredibly important. And again, that's probably the result of compromised oxygen to the infant through the placenta. Next slide. And here you can see the yes from these women, and they were abused badly enough that they called the police, or the police were called by a neighbor. So those are more severely abused women. But we did find a very concerning amount of losing consciousness due to strangulation, and also losing consciousness from other head injuries. But almost 24% of them had lost consciousness due to strangulation, which is incredibly concerning. 7 months later, in just that interim, 2.6% of the women had lost consciousness due to strangulation again. Next slide. And the DA5, this is a short form of the danger assessment that's meant for the healthcare system, is available on the website and with a protocol to go with it. And we have, as one of the items, number 4, has your partner or ex-partner ever tried to choke or strangle you? If yes, did he ever actually do it, ever actually choke you? If yes, about how long ago? Did it happen more than once? And did you ever lose consciousness or think you may have? So again, a little bit different wording that's more appropriate for the healthcare system. But again, getting those items into even the shortest form of the danger assessment is incredibly important. Next slide. And then the protocol that goes with the short form of the danger assessment, if there's 4 or 5 responses, and this is somewhat similar to the LAP kind of protocol, to tell the victim she is in danger. It's very important for victims of domestic violence and strangulation. If they are at high risk to be killed, they need to know that. They need to have that information, and that's incredibly important. And we always say victims need to have choices, so they can choose reporting to the police and or to a domestic violence advocacy program and or a confidential hotline. And then we tell the provider, make the call with the victim. And especially important in this day of electronic stalking, she may not be able to use her own phone to call a domestic violence hotline. And so we in the healthcare system, we need to offer the call to her, or an in-person handoff to a knowledgeable advocate. 4 to 5 responses, that's very high risk, extreme amount of danger. 3 of 5 yeses, then we recommend that a full danger assessment be done with her and the weighted scoring. And inform again the victim of the level of danger and do safety planning based on what she said yes on the danger assessment, or refer to someone who's certified in administering the danger assessment. If 2 of 5, you tell her there's 2 of 5 risk factors for serious injury, serious assault, or homicide in her case, or his, and recommend further advocacy. If the victim agrees, follow through with a referral, again, preferably in person or voice to voice on a phone and with the victim. And you can use a speakerphone or 3-way call so that she's actually handed off personally to a knowledgeable advocate. And even if there's one of those, you're going to proceed, or none of them, she has disclosed domestic violence, so you're going to proceed with your normal referral procedures for domestic violence. Next slide. And the brief strangulation protocol is now also with the DA5. And then if strangulation was a week ago or less, remember she's in a healthcare setting. So go ahead and examine the inside of her throat, her neck, face, and scalp for physical signs of strangulation, as well as using strangulation protocols from the National Strangulation Institute. So we provide that, a link to that website with the protocol. Proceed with emergency medical care for strangulation, especially if there's been any loss of consciousness or possible loss of consciousness. Again, victims are often unsure. If she actually lost consciousness, she will usually become incontinent. She will wet herself, and we need to ask about that because oftentimes people are very embarrassed if that happens, and they're not going to volunteer that information. If there's been more than one strangulation, we as healthcare providers need to either conduct a neurological exam or get someone who's more knowledgeable about that to conduct a neurological exam or refer for an exam and inform again her or him of increased risk of homicide. And in many states, there's the mandatory reporting of a severe injury, like with a gunshot injury or a knife wound. And I think that strangulation ought to be included there because it can potentially cause death also. But for now, if your state doesn't have any kind of mandatory reporting for strangulation, we ask the victim if they want to have the police or prosecutors notified, and we need to know whatever our state law is on strangulation, and whether or not the victim needs to know that this medical documentation of strangulation can be used later if they decide they want to substantiate the strangulation. It will be in her medical record. Next slide. And I end up with a quote. This is one of the moms of one of the homicide victims in the original study, who said that if I'm going to talk about what happened to her, I need to say that at the end. Thank you.
Earl, you're muted.
Gracious, it gets me every time. I'm sorry. Thank you, Dr. Campbell, again for all your wisdom and your insight and all of your hard work with strangulation. We know that these are tough subjects to cover, but thank you again for having that fortitude to push on and really assist victims who are struggling in these various areas, especially with strangulation. So now we heard from law enforcement. We heard from Dr. Campbell, who gave a very good explanation of strangulation and why it's important and why we should preference strangulation, right? So now we're going to talk about what does the data say. So with that, I'm going to turn it over to Jill Messing. Jill Messing is a professor in the School of Social Work and the director of the Office of Gender-Based Violence at Arizona State University. Dr. Messing specializes in the development and testing of intimate partner violent risk assessments. As a social worker, she is particularly interested in the use of risk assessments and collaborative and innovative interventions, and as a strategy for reducing intimate partner violence and homicide. So without further ado, Dr. Jill Messing.
Great, thank you so much. And today, Dr. Campbell and Dave Thomas talked a lot about the evidence around strangulation. And so those are all really good reasons to prioritize strangulation in risk assessment, including the lethality screen. But the Maryland Network Against Domestic Violence reached out to me to make sure that the change was evidence-based. So they wanted me to do some statistical analysis to make sure, that we're keeping the predictive validity, or the validity of, or the ability of the lethality screen to predict what happens in the future, either the same or better than it was previously before moving strangulation. Next slide, please. I'm just going to talk very briefly about the lethality screen, and then I'm going to go over predictive validity and especially sensitivity. We're going to talk about the data analysis that I did for this change and what I found. And then I believe we're going to move into discussion and questions. Next slide, please. So, and I'm only going to make a couple of points just so you have them in your head as we talk about that, as we talk about this. So, as Dr. Campbell said, when we did the research on the lethality assessment program, what we found is that when victims screen in as high risk and then are connected to an advocate on the telephone, they're less likely to experience violence in the 7 months, in the 7 subsequent months. And they're also more likely to reach out additionally for help for services. And then we've also been working on strangulation in the realm of the other versions of the danger assessment. And Dr. Campbell talked a bit about what that looks like. Next slide, please. So when we think about predictive validity, that means how accurately so validity is accuracy. So how accurately can we predict a particular outcome? And when we're looking at the lethality screen, we do a few different analyses. So we look at whether the outcome of near fatal violence, how well that's predicted, severe violence, any violence, and then we actually will look at intimate partner abuse as well. So it's really important for a risk assessment that it does a good job of predicting what happens in the future, right? And so in this example here, it is how well our net catches the redfish in the net. Next slide, please. So there's 2 main parts of predictive validity. So specificity is one of those parts. And specificity means the lethality screen's ability to identify those folks who are not at high risk, who do not experience violence on follow-up. Next slide, please. Sensitivity is another main part of predictive validity, and it's the lethality screen's ability to screen in those who experience violence, in this case, in the subsequent 7 months. So you can see here that we've caught almost all of those redfish, and the lethality screen prioritizes high sensitivity. So that's because we want as many people as possible, or as many people as may experience violence in the future, to speak to that advocate. There's not really a downside of screening in some people who will not experience violence in subsequent 7 months. Perhaps they'll experience violence later. Perhaps that advocate, can help them with their situation as well. So there's not really a downside of having some folks participate in the intervention who are not going to experience that violence in the subsequent 7 months. But it's really important that we get as many of those folks as possible to speak to the advocate who will experience that violence in the subsequent 7 months. Next slide, please. So these are the tables that help us look at sensitivity and specificity, as well as positive predictive value and negative predictive value. I'm not going to talk about those. But what you can see here is that sensitivity, it goes up to 100%. So it would be very difficult, but we possibly could have an instrument that's sensitive enough to screen in every single person who experiences, in this case, violence at that subsequent follow-up. But the first thing that we're looking at is near fatal violence. So this is the original lethality screen, and you can see this yes column here. Because out of 28 people who experienced near fatal violence on follow-up, we screen in 26 of those with the original lethality screen. And those are the analyses that we did with the Oklahoma data. And so that gives us a sensitivity of about 93%, which is very high, which is what we want. Next slide, please. And so when we look at the lethality screen with strangulation above the line, you can see these two yes columns, and I didn't line them up perfectly, sorry about that. But you can see in these two yes columns, right, same outcome, near fatal violence on follow-up. And you can see that of the 28 folks, we still screen in 26. So our sensitivity, again, about 93%, is the same when we put strangulation above the line in the new version. And we can also look at different types of violence on follow-up. Next slide, please. So if we look, this is a comparison looking at the prediction of severe violence. So if we look at severe violence on follow-up, you can see again in this yes line that 44 people of the entire sample experienced severe violence on follow-up. And you can see again that on the original lethality screen, we're screening in 41 of those folks for a little over 93% sensitivity. And on the new version of the lethality screen, we're also screening in 41 of those folks for about 93% sensitivity. In this example as well, one thing to just point out is that we are screening in a few more people. So we have a little bit lower specificity. Next slide, please. So we can look now at any violence on follow-up. And if you look at if people experience any violence on follow-up, you can see again in this line, 69 folks are screened in, or 69 folks experienced out of the full sample, experienced severe violence on follow-up. And with the original lethality screen, we screened in 60 of those for about an 87% sensitivity. With the lethality screen, the strangulation above the line, we screen in one more. So we screen in 61 of those folks for about an 88% specificity or sensitivity, sorry. So we're doing a little bit better in terms of sensitivity when we look at any violence on follow-up. And you can see also again that because we're screening in a few more people, our specificity is a little bit lower. Next slide. And then this one is a comparison for the prediction of any abuse. And so we can see that once again, and so this would include, any abuse, including verbal abuse, etc., on follow-up. You can see here that 148 folks in the sample experienced any abuse on follow-up. And the original lethality screen screened in 124 of those at high risk, whereas with strangulation above the line, we're screening in 130 of those folks, so a few more of those at high risk. So our sensitivity again is a little bit higher. Because we're screening in a few more folks, our specificity is lower. Next slide, please. All right. So this is where I tell you the bottom line, which is that when we move strangulation above the line, the sensitivity of the instrument remains the same, or it gets a little bit better, depending on the outcome. Because we're screening in more people, the specificity decreases slightly. But what we really want to focus on here is that sensitivity, right? Our sensitivity is good, right? We want to get as many folks as possible who may be high risk speaking to that hotline counselor, because that is where we get the outcomes of people experiencing this violence, seeking more services. And then, as you've heard from Dave Thomas and Dr. Campbell, strangulation is dangerous, right? We need to be connecting folks who have experienced strangulation to the appropriate interventions. And then again, I've said this a few times, but those survivors who choose to speak with an advocate experience less subsequent violence. Next slide, please. And then I also just want, I use this risk-informed or evidence-based intervention model a lot in my work. And so I just want to remind folks that the lethality screen is going to be your best evidence of future, near fatal violence, severe violence, or abuse, right? That's going to be kind of the best tool that we have to understand whether violence will occur in the future. But we also need, when we're using a lethality screen at the scene, we also need to incorporate that officer expertise. And that's why we have the little check, the option at the end that officers can screen in anyone at high risk if they have concerns about that person. Right, so we need to incorporate that expertise so that if an officer has a concern, they can screen in that person to speak to the hotline concern. And then finally, the last part of an evidence-based practice intervention is making sure that we allow survivors self-determination. And so survivor choice is another important part. So survivors get the choice about whether they want to speak to the hotline counselor or not. Thank you. That's all from me. And this is just some information if you want to follow me on social media, or you can email me if you have questions, but right now we have a chance to answer questions as well.
Thank you, Jill, so much. So now what we're going to do is we're going to talk about the information that we received. So as Dave put it, strangulation is very important. You know, that people who strangle, the likelihood of lethality is higher. Dr. Campbell also supported that. Also, we talked about not being able to really tell if someone was strangled. So, you know, it's a very serious thing. As a lot of people know, the difference between strangle and choke is essential. So using the appropriate language, because a lot of people, when you say choke, you think of two hands around your neck or something being lodged in your throat. But strangulation is the preferred term to identify someone cutting off your breathing. And as Dr. Campbell say, you know, using the forearm is one of the ways that can happen and does happen. And we've heard all of the symptoms and all of the things that can happen from strangulation that may not people may not know. And utilization of the danger assessment can be a great tool to help victims, you know, navigate through those waters. Okay, so now as you see, this was kind of our process and how we looked at the lab tool, right? We gathered all of this information that you just previously heard, and we looked at the tool. And as Dr. Messing stated, that, you know, moving the strangulation question above the line did not change the sensitivity. It still was around that 93%, right? So there was no real change to the tool or the amount of people that would be considered high danger, right? Now, a lot of people, you know, may still have questions about switching the question because, you know, does it take credence away from the other question? No, it doesn't, right? But if we cast the net too wide, as you saw in Dr. Messing's diagram with the fish, if we cast the net too wide to capture more people, then what is the point of having a screen? We would just have everyone screened in this high danger. And that's not what we want, because that wouldn't be conducive for programs nor for victims, right? We want to make sure that we're catching the most people who are at the highest level of danger or imminent danger of being killed, okay? And gathering all this information, and as the advisory council, we came back together with this information with Dr. Campbell and Dr. Messing, and really put all of this together to have a decision. So the decision was made to move the strangulation question above the line, right? So that's where we are with that, and with the tool. We wanted to use this time to really have everyone understand why we did this, and what was the methods and data that we use to make our decision, right? And, you know, we just want to take this time to give you a few keys on what we think is going to help you, or things that are helpful for you if you're considering implementation of the lab. Right. Without further ado, I'm going to turn it over to Lena, who is our Maryland lab lead. So Lena.
Thank you, Darrell, and thank you, everyone. Thank you to all our presenters today. I'm seeing a lot of folks who are implementing the lab nationwide, so excited to see you all here today. And as Darrell mentioned, we've gone through our process today on how we landed here. And so because we're talking about a revision to the screen, I know many of you who are currently implementing are thinking, oh boy, we need to change our form. And so we wanted to go ahead and give you a couple of tips and suggestions on how to move forward with that. It really, for small implementing jurisdictions, it shouldn't be too taskly. It should be something that you just need to communicate, have the screen ready, have the new screen ready for implementations, and it should be a smooth process. Now, for those who have a number of implementers or are doing so statewide, we have a couple of statewide implementing states. And so thinking through that, here are a couple of suggestions that we make. You want to make sure that all your agencies are notified of this change and ensure that they have been notified. So you definitely don't want to just count on one person or your lab coordinator, because we want to make sure that, you know, sometimes people are out of the office or they move on quickly from positions. And so you want to make sure that every single implementer has been notified before moving forward. You also want to give folks about 2 to 3 months. If you feel you need to provide more time, you can do so. That might just get a couple of agencies a little antsy because they might be able to go through their internal approval process quicker. Keep in mind there is a variety of approval processes that some agencies have to take whenever they make any type of changes to any of their forms. And so keep that in mind when you are placing a deadline. What you want to do is just continuously survey the readiness of agencies. Again, you want to make sure you do that for every single one that is implementing, and not just your lab coordinators or your team leads, to make sure that everyone is on the same page. And then you want to make sure that once all that's ready, then you announce a rollout date and provide training material, and you can do so 1 or 2 months prior to that. You know, as anything, this just has to be something that you have to do with a lot of flexibility. So we would just encourage a lot of communication and making sure that everyone who needs to be notified that this is happening is involved to make sure that you all can move at the right pace. So as always, all of our lab implementers nationwide, please feel free to reach out to us. We'll be happy to support the transitions. And as you know, we have a lot of changes coming, so we're happy to support any of these changes coming our way. So now we're gonna move forward to our Q&A section. Thank you so much.
Yeah, thank you, Lena. Again, any questions about implementation, you can email us at info.lap@mnadv.org, and we'll address your questions as soon as possible. Again, we do have a survey. We ask that you scan the QR code and take the survey. We ask this information because it's going to help us give better trainings in the future. And this information is valued. You guys are part of our community, our colleagues, and your input is very important to us. So please feel free to fill out the survey that we have. Again, the QR code is up. You can take your phone and scan it, and it'll take you to the link to the QR code for the survey. Everyone else, have a great rest of your evening. And again, feel free to reach out to us if you need. Thank you.